I'm Eric Wimmers. I'm a plastic and reconstructive surgeon. I'm board certified in plastic surgery. So breast reconstruction is reestablishing the physical form of female breast after mastectomy or even after a lumpectomy. The choices for breast reconstruction are multifold. My primary two types of reconstruction include implant-based versus autologous-based reconstruction. So implant-based, as you know, is using a silicone implant to replace the breast tissue. Autologous reconstruction is using the woman's own tissue to reconstruct the breast. Commonly, we take tissue from the lower abdomen, which is called a DIEP flap, D-I-E-P. But there are some other options such as the latissimus muscle and some various other areas of the body which can be used for autologous reconstruction. If a woman has had previous radiation treatment or is expecting to have radiation treatment, I generally will guide a patient to have autologous reconstruction because that type of reconstruction does better in the face of radiation damage. However, in another patient who is not expecting or haven't had radiation, implants may be the best choice. Implants are easy on the patient, they're also easy on the surgeon, but they don't have as long-lasting effects as, say, when we do autologous reconstruction, which is forever. So regardless of whether a patient is having implant-based reconstruction or autologous-based reconstruction, my pathway for reconstruction starts at the same starting point. At the time of the mastectomy, I'll be present, and I'll also place a temporary type of implant called a tissue expander. And that allows the pocket to heal in the space where I want the footprint of the breast to be. Then at a subsequent procedure, after any other necessary treatments are performed, then we can complete the reconstruction with either an implant or the autologous reconstruction of our own tissue. So let's talk about autologous reconstruction. So that pathway starts the same as the implant-based pathway with the placement of the tissue expander at the time of the mastectomy. Then, after all the other treatments are performed, if necessary, we do the final reconstruction, which is at least 6 weeks later, most commonly about 3 months later. We do the larger operation, which is the DIEP flap procedure. So the first operation at the time of the mastectomy is an overnight stay, about a 3-hour surgery, and pretty well tolerated with a 4-week recovery. Some expansion of the tissue expander is performed, and then when we come back for the DIEP flap procedure, that's a larger operation. For a bilateral case, it's about an 8-hour surgery, 3 days in the hospital, and about a 4 to 6 week recovery. The recovery for this surgery is much different than in the first operation. At the first operation, mastectomy, all the discomfort, of course, is in the chest area. But for the second operation, all the discomfort is in the abdominal area. In terms of the reconstruction, though, what I always tell patients is that the reconstruction comes second. The first and foremost, the priority is treating the cancer. And that can be surgical excision, it can mean radiation or chemotherapy. Some of those decisions occur after the mastectomy is formed. So breast reconstruction will not affect the recurrence of your cancer. This has been studied extensively, and it's something that has worried scientists in the past if moving tissue from somewhere else in the body could reactivate cells to cause a cancer recurrence. And this has been shown extensively to not be the case. So reconstruction will not affect your cancer.